taken on this. It's critical that all of us, I think, give this some attention, even though actually I don't think it's getting as much attention by governments or our healthcare system as I would expect. It certainly gets attention to the extent that governments can conclude that they can no longer afford the annual 6% plus increases that we've seen year after year for quite a long time. And I think we in healthcare talk about it in the context of how we're going to balance our budgets this year and even next year. But this type of discontent that we share doesn't often drive the creative and constructive conversations on how we might reform the system and so that we can live within the realities of the financial situation of what Canadians can pay. So who's accountable for this lack of concern and lack of action? So Jeffrey Simpson from the Globe and Mail recently published a book that some of you may have read called Chronic Condition, Why the Health System Needs to be Dragged into the 21st Century. And in that book, he lays out what he feels is the plain truth about our current system. He says he wrote the book for reasons that I'm going to speak to, that we as Canadians need a wake-up call as to the current state of our system and the fact that it will not sustain us into the future, and therefore we need to find the will and the accountability to make the needed changes. So he's documented his concerns that are summarized on this slide, which is that Canadian healthcare produces only average value for money, and it's regularly rated at average or slightly below average in international comparisons. Outside of Canada, there are other systems that provide superior service at lower cost. And these conclusions that he presents are not the conclusion of just one study. You'll see in the book that he's documented multiple studies that come to pretty much the same evaluation of our system. And then he also documents how the growing cost of our system produces just average outcomes and how that's squeezing out the funding for other important investments that we value as a society, many of which are large contributors to population health, such as education, housing, social programs, economic investments, infrastructure. So using Jeffrey Simpson's phrase, we're paying Cadillac prices for Chevrolet service, which I think really just says it all. And it's okay to do that if money is not an issue, but of course it is and will continue to be. And I still remember reading Les Vertesi's book, who's going to be speaking to us, Broken Promises, which he wrote quite a long time ago, where he paraphrased it, but he speaks about how amazing it is that the system works as well as it does. So I think what we're trying to stimulate a discussion around is why is this, and who is accountable or responsible for taking action to keep us from heading over a fiscal cliff of unsustainability. So going back to the theme of today, who is accountable and responsible for making the necessary changes to keep us from falling off that cliff? And here I've listed the usual suspects who all seem to have a role. And yet none of them, and us, seem to be pushing this conversation particularly or making the very hard changes that might be necessary for rescue. The care received today at great financial cost, and I would add actually great personal cost of our many devoted staff and physicians, is very good, and there appears not to be a strong will to take this on. In the last couple of weeks, I've been part of two debates, or witnessed two debates, both at the federal level and at the provincial level, where healthcare was not mentioned once. They spoke of the economy, education, Aboriginal rights, the environment, but not healthcare. So there are many areas, I believe, where we need to take action quickly to turn this big ship, and some are controversial and some take money. And these are the types of issues that whoever is accountable should be talking about, in my mind, and gaining consensus to address. So we know that we don't have good communication records. I believe that the most influential human resources in the system, which are the physicians, are not seen normally as the system leaders. They're kind of on the side. More and more, I'm thinking part of the challenge is that we're all very smart, professional, passionate, and independent thinkers. That's how clinicians are raised to be and educated to be. But boy, it makes change hard because you really have to convince one by one for folks to buy into a change because of the independence of their thinking. Our infrastructure doesn't support new and modern services. But perhaps most importantly is the lack of alignment of our incentives to improve the system and to provide better quality and more volume for the same or less cost. Our physician and union agreements don't support this thinking, and our funding formulas, like activity-based costing, start to do this, but there doesn't appear to be the universal enthusiasm to continue and to grow this type of funding formula. In any case, there's not a huge drive or a big enough drive in my mind to structure a system that pays for this value. So we lean on historic payment structures that I don't think can get us where we need to go. So back to the theme, who's accountable and for what? Well, here's my view. I see three key areas where we need to move forward quickly to bring our healthcare system to the next level of sustainability. Firstly, we need to continue and increase the pace on reducing the waste that exists throughout the system. So IHI, the Institute for Healthcare Improvement, and Kaiser Permanente, and even last week the World Economic Forum, they all estimate that the waste in Western healthcare systems is somewhere between 20 and 40%. So you know the opportunities as well as I do of things that we can do to become more efficient in terms of doing things correctly the first time, reducing rework, and stop doing things that don't make a difference. And certainly, we're clearly, as healthcare providers, we are clearly accountable for this. And of course, we know how to do this. We do it every day. Yet most people who study healthcare say that just finding efficiencies alone is not enough to save the system in the longer run. However, it will buy us time to do some of the other necessary actions. And one of the actions is to bring truly disruptive innovation into the system. And disruptive innovation, in the sense that I'm using it, is innovation that makes a system that's complex, expensive, and accessible only to a few, available to the masses due to an increased simplicity and an affordable cost. So we've seen that in other industries. Examples would be the movement from mainframe computers to personal computers and now iPhones. We see it in banking, going from traditional in-person banking to online computer banking. There's multiple examples of where we've gone from a very complex, sophisticated system that requires very highly trained professionals and brought that down to the masses. So healthcare has been very slow to develop and adopt these types of innovations that could make our system more affordable by starting by separating out what is routine, predictable care and allowing non-physicians to deliver that, by using personalized medicine to target specific diseases as opposed to the current scatterbomb approach, which is much less effective, trial error. These kind of concepts, I think, need to be explored and to be acted upon. If you're interested in more about this thinking, a lot of this is described in a book called The Innovator's Prescription by Clayton Christensen. It really talks specifically about how you can change the availability of healthcare services and the cost curve of these services. And so who can do this type of work? Well, in my mind, these types of innovations and moving them into mainstream healthcare beyond the pilot stage is really best done in partnerships with government, industry, universities, researchers. But we, of course, as healthcare providers, need to embrace these possibilities and be open to these types of changes. And then thirdly and lastly, we can't forget about the alignment of the incentives for the key stakeholders in the system. Going back to the fundamentals that we need good outcomes at an affordable price, but our system does not incent this. Hence, we pay Cadillac prices for Chevrolet service. We need to make the necessary and difficult changes to pay for outcomes, not volume. We need to acknowledge that these types of changes take strong leadership skills, and so we need to train and hire not just for clinical skills, but for leadership skills at every level of the organizations, physicians, nurses, allied. And we as users of the system can't get off easily either. We need to be participants in our health, and providers and government need to ensure that we take this responsibility. So again, these are really big changes that need to be led by government with our support. So we really are an elephant. We're huge, we're monopolistic, somewhat clumsy, and can we really do this? I would suggest a change of this type is probably the very hardest type. Big companies, big bureaucracies don't often change, or if they do, they wait until it's too late. There are very few examples in business literature of this type of successful change, and it's usually done by separating a piece of the company and running it totally separately so that it can have its own culture, its own rules, be nimble, quick, entrepreneurial. Some have said even that the U.S. system has a better chance of achieving sustainability than a universal healthcare system, because the U.S. system, as bad as it is, it's chaotic, it's fragmented, there's multiple rules that are driven by private and yet entrepreneurial interests. But that if it can be done within a regulatory framework that protects the individual, maybe it's more nimble to produce the change that's needed. That said, we can't afford to fail, and it'd be a failure of our society. And we know that there's other universal healthcare systems that do significantly better than we do in terms of the balance between quality and cost. Those are like the UK, Australia, France. And that's why we need to have this conversation around the need to change and the role that each of us can play and who is accountable for driving that. So thank you for that. Thank you for listening. Julian?
Excellent. Thank you. Thank you very much, Mary. And so I'm now going to pass the presenter controls over to Les. And Evelyn will need to unmute call-in user 4, if that's okay. And then when that's done. So I'd like to introduce Les Vertesi. Many of you know Les. He is an emergency physician at the Royal Columbian and Eagle Ridge Hospitals in Fraser Health Authority, and has been there for quite a long time, longer than me. And I'm not in Fraser Health, but he's a very accomplished individual. He's now the executive director of the BC Health Services Purchasing Organization, which has a large part of the incentive funding being rolled out in BC around healthcare, and has, as Mary mentioned, written books on this healthcare system, and so will be very insightful and thought-provoking in his presentation on how to change accountability in the healthcare system. So, Les, if you're okay, I'll just hand the ball over to you, and thank you very much also for doing this.
Thanks very much, Julian. I think I can go to my slides. That's it.
I can hear you.
Okay, great. Thanks. So it is actually a great opportunity to talk about this. It's an abstract subject, and I found it a little difficult at first to put together an approach, and I put together something that is a bit unconventional, and I hope you'll all bear with me as we do that, walk through that. I think it needs an unconventional approach because, as I'll get to, is we have to come to terms with a few very basic questions. First of all, why have we been talking about this for 20 plus years and getting nowhere? We're still talking about the same questions in Canada on accountability in healthcare, and I don't see a lot of change. The other question we have to come to terms with is, why does it keep coming up in healthcare and we don't talk about it? It's not a big subject in other industries anywhere in Canada or other places. I'm talking about the McDonald's or the Holiday Inns or what have you, an industry that surrounds us, and even the Apple iPhone that I'm using to call in on. It doesn't seem to be a big question outside of healthcare. Why is it healthcare, and especially Canadian healthcare, that it seems to keep coming back all the time to haunt us like bad breakfast? So in order to get at that, I think we have to get out of healthcare for a moment and talk about something completely different and look at it. And I've taken a very simple problem, and excuse me for the analogy, but let's assume that you have a leaky toilet in your bathroom. This is a problem, and so what do? And of course, what you do is you get a plumber, right? And you hire a plumber, and he says, I'm a plumber, I know how to fix this, I know how to put in a new toilet, and so on. And he does it. He comes in, and he puts in a toilet, and so on, and that's not accountability by itself. But what if the new toilet leaks? Problem is, if it leaks, then you come back to whose responsibility is now to fix the leak. Whose responsibility is it to fix the leak and maybe pay for the damage that the water has done to the ceiling and so on. And of course, that's what accountability is, because in contract law in Western societies, it's very clear who's accountable. It's the plumber who installed it who has to fix it, because a contractual framework existed before you even went to him to commission the work. He said he was a plumber. He's got his qualifications. He laid out a price. You paid him the price. You have an expectation, a prior expectation, and you're entitled to have an expectation to have that work done properly and without any complications, and he's certifying that. So you have a right, in other words, to expect a certain level of quality. So, fine, let's see what happens in Canadian healthcare and move over sideways here and see what happens when you get sick. Well, we all know you get sick, people look after you, and in general, we do a pretty good job of looking after sick people, and it's free, which is wonderful, and we talk a lot about that in Canada. And that's great. But what happens when something goes wrong? And you all know what happens when something goes wrong. The question goes back to, well, whose responsibility is it to fix it? And more importantly, even whose responsibility is it to make sure that same thing never happens again? And there isn't any clarity in Canada about whose responsibility it is. Like, is it the health authority? Is it the hospital administrators? And you see a list here. It's very similar to the list of, I think, what Mary called the usual suspects, which is exactly right. And we go around and we look for someone to blame. And, of course, each of those people groups look around for someone else to blame. And that's exactly the problem. We have no clear framework for who is to take responsibility. So, of course, the natural human thing happens is we all tend to blame someone else and try and get someone else to fix the problem. And that's why I think many things never are fixed in our system. And they keep piling up. So we've now accumulated a series of things that have never been addressed, never been fixed, layered one on top of another. And it makes a problem much worse because it's now become very complicated and hard to break out. So accountability, we come back to the word because this is what we're trying to define. It needs clarity, first of all. It needs a framework of clarity. We need to be clear on who the providers are, who the recipients are, what the service is, especially what the value of the service is. We can't assume there's services don't have a value. They have a value, and they have relative value. Some services are more than others. Some services cost more than others. And so we have to have a system for adjusting those values and the cost together. We also have to have an expectation for quality. It has to be clear as well on all sides. Everyone has to know what we're expecting in quality, and when we don't achieve it, that there's a problem that has to be fixed. And this is something that has to be not just on one side. It can't just be government saying, here, we expect this. It has to be everyone participating has to have the same picture of what people expect, and also who will take responsibility for fixing the problems when the inevitable happens. Occasionally, the expectations aren't met. So it comes back to we all actually are working very hard on it, all of us, I think, in healthcare. And in fact, if you look at why things are as good as they are, it's because we have thousands and thousands, hundreds of thousands of individuals, dedicated professionals working very hard. And this is something that we sometimes mix up with accountability. I think professionalism and accountability, sometimes the words blur a bit, and the images we have for them are a little bit faint. I mean, I think people mix these up. So we all try to work with a sense of professionalism. Certainly doctors have a professional code of ethics and enforced by the college, and so do other health professionals have something comparable. Even, believe it or not, the health ministry and the people who work in government all have some idea of professional ethics and doing, but they're all working in their own little areas. And that's not what accountability is. Accountability is putting these things together into a framework, so that actually it's the framework that has to be accountable. The individuals work at their professional levels, but the accountability has to refer to the whole system as a whole. And there's one element missing here, and so far in this diagram, we have to come back to, and that is the dollars. Without the dollars, this framework is going to waffle. It's going to move around. It's not going to be fixed. It's going to change. People are going to have different ideas, and there isn't any way of pinning it down. So, the dollars are actually really important. And we think of it as always saving money. And in fact, we're told in Canada implicitly, I think, that money's not important in some way. But by that I mean money's not integral to accountability. Accountability is a separate issue. People should be accountable without, reference to money, which is, of course, nonsense. And if you don't believe that, first of all, I don't know too many people who want to keep working without getting paid. But that's not the point. Think back to our plumber. Think back to our plumber who came to do the work. Is it possible to get that work done, fixing your leaky toilet, without paying for it? Yes, absolutely it's possible. You could have had a neighbor, a friend, who's a plumber, who says, yeah, you know what, I'll come and fix your toilet. Fine, he fixes the toilet. But if something goes wrong and the toilet leaks and you've got damage, do you think for 1 minute that person who came to fix your toilet for free is going to say, no worries, I'll take responsibility for fixing the problem? I don't think so. And that's where, again, this is the trouble. When you don't actually connect the dots of the dollars with the work and with your responsibility, you get adrift that actually you get lost in who is responsible. So the money is important, and pegging the money to the responsibility is important. It's not just the amount. Now, if there's an infinite amount of money, as Mary said, then maybe it doesn't matter because we can just keep piling into it and keep layering on and doing as we are. But that's not going to happen. We're already coming to the edge of what people can afford, what the government can afford. And once the money gets tight, then things start to trip up, and then that is what's going to force change. So we come back to accountability, which is, we want to define it. We want to get a handle on it. And I want you to notice that the word accountability includes count, which means counting. In other words, you can't have accountability without the ability to count. The ability to count services, the ability to count value, the ability to pay an acceptable amount, and that has to happen in a framework. So I'm going to end this by saying that this may seem way way beyond what most people who actually work in healthcare at their own individual professional levels can have a handle on. It can be very frustrating. Well, how do I get to that level? Well, you can't, of course, and that's been very frustrating. But I want to reassure you that that doesn't mean that no one is working on it. It's a large part of what we at BC Health Services Purchasing Organization, fondly known as HSPO, to some is trying to do. Some people think that we're just trying to create more of something, buy more widgets, buy more colonoscopies, buy more of this, buy more of that. And they think that, some of them, but that's not it at all. What we're trying to do is create this framework where money is tied to services, money is tied to value, and there's some clarity in who provides what and who's responsible for what. So with that teaser, I think I've used up my 7 minutes or whatever it was, so I'm going to end at this. Thanks very much, everybody.
Great. Thank you very much, Les. That was fantastic. And now, Grant, if I could ask you if you can see your computer screen okay.
Yeah.
Great. So Grant Innes, many people know, is Professor and Chair of the Division of Emergency Medicine at the University of Calgary. He's the Department Head of Emergency Medicine for the Alberta Health Services Calgary Zone. So thank you also, Grant, for doing this, and welcome. And I'll hand it over to you now. Thank you.
Thanks, Julian. And so I'll spend 10 seconds of my 7 minutes just encouraging people to attend the WEDOC conference in Calgary at the end of April. I think it's going to be really good. And moving on to accountability, it seems like we have a lot of major problems in our healthcare system. And when I thought about the problems, you can't get decent parking near a hospital. We have to deal with patients. They're always complaining about their problems. And, doctors aren't making enough money. But I guess we're supposed to be patient-focused. So I tried to think what might be the biggest problem from a patient perspective. And I think this is it. I think a lot of patients are finding it hard to access care, and they're waiting for care in the wrong places. I think it may be true that we're lacking capacity in the system and that we have a demand-capacity mismatch. But despite this, we're not doing nearly as well as we could be doing with the resources we have, which Mary alluded to. The reason I think we aren't doing as well as we could is because we don't have to. Providers individually, programmatically, have no accountability. I think there really is no accountability in our system. So I think accountability is what happens when a patient can't get the care they need. My mother recently had surgery, quite complex neurosurgery. She said the neurosurgeon was great. He was really concerned about her. When she was discharged, he explained that this was really complicated surgery, and if she had any problems, she should go immediately to the emergency department. As it turned out, she did have some problems. She went to the emergency department, and she was quite annoyed to find out that the emergency physician didn't know anything about her surgery, and that the emergency physician really wasn't aware of a process where the emergency department was supposed to look after post-op complications. There's many other examples of accountability gaps whereby the system doesn't address patient needs and doesn't even really have a plan to meet those needs. So you can't get a family doctor. Maybe you have a family doctor, but the recorded message tells you go to the emergency department. You've got an acute neurologic problem, so you get put on a 1-year waiting list. This is a real case I saw recently. Or you get put on a 1-year waiting list to get an MRI. The entire health system basically shuts down for 85% of the hours of the year, which is true. You can't get a bed in the hospital. Someone in the emergency department will look after you. So it kind of seems like the default solution to most of the system gaps is to go to the emergency department. This is kind of a displacement strategy, but it seems like increasingly more and more and more patients are getting the wrong care in the wrong place at the wrong time. And from the perspective of an emergency department, because I think that's mostly who our audience is today, the safety net role we're trying to fulfill is becoming way too big. So in preparing for this talk, I looked up the word accountable in the dictionary. To be accountable, you are answerable to someone or for something. So I think accountability in healthcare must mean accountable to provide patient care for your patients. Now, some of you, when I say that, will start feeling a little defensive. Many of you will have felt the hair rise on the back of your neck. You will have thought immediately, what does he mean, my patients? And so I want to bring up the concept of accountability zones. So if we pretend for a moment that we actually do have a healthcare system and that someone is developing a plan to provide for the healthcare needs of the population, presumably one of the first things you would do would be identify some functional units. We could call those programs. And these units are accountable for the needs of specific patients. So the accountability framework would clarify which patients and when care accountability begins and ends. If the people and the providers and the programs in our system don't have an understanding of what they're expected to do, or if there is no accountability framework, then they really have no need to develop solutions. And as a system, we don't know who we're supposed to go to develop those systems. And I think in our system, accountability is exceedingly unclear. So I have a skill testing question to illustrate accountability zones. What service would provide the best care for a psychiatric patient requiring inpatient hospitalization? The ICU, the emergency department, the Department of Psychiatry, the Department of Respiratory Medicine? Well, it seems like a fairly straightforward answer, but sometimes it's not always so clear. What we often hear is, well, for a variety of reasons, we can't provide that care. We can't be accountable. So then I would ask the logical follow-up question, which is, if system capacity or efficiency shortfalls compromise access for psychiatric patients, who is best able to determine real psychiatric program shortfalls, appropriate staffing, reallocation of resources questions, space requirements? What are the best possible solutions? What are the innovations in mental health care? In other words, where do we look for the solutions? So from my perspective, we have this big system, and we have a number of silos in the system. And in this diagram, each gray area is a silo, but I'm going to call it an accountability zone. And so theoretically, the emergency department is responsible for any patients who are referred in, come in by ambulance, walk in, anyone who presents to the front door. The inpatient silo is responsible for patients who are referred for inpatient management, and community long-term care silo is responsible for patients who can live independently in the community, and for patients who don't require hospital care any longer but perhaps can't live independently at home. So in my ideal world, every patient has a home, and ideally every program has some kind of a plan to provide care for its patients. I don't think displacement solutions are the answer. I don't think you can solve the problems by shoveling your snow onto the neighbor's driveway. I thought I should use that in case there's anyone from Edmonton, because it's something they can understand. So providers in the system may or may not have exactly the same perception of this. And when you talk to people in the system, I think most of them do not have a system view. They don't feel accountability for all the patients. They feel an accountability for the patient who's sitting in front of them. I think this is based on a misinterpretation of the Hippocratic paradigm, which we all learned. And I think many of us believe we are supposed to advocate for our one patient and provide ideal care for the one to the detriment of many others. So patients who have not been granted admission to our units we don't see these people as our concern. And the lack of an accountability framework in healthcare, I think, allows providers and programs to practice in whatever way we want, to use our resources without respect to the collective patient need. So a phrase I like is supply-demand resource management. And I think this means you allocate your resources with a view to the collective demand that you need to address. So Mary had a great analogy about vehicles. So I think if you wanted to buy a car for each of your 3 children and your total budget was $50,000, you're probably not going to buy your oldest child a Mercedes. Okay. Accountability for what? What are we talking about? I think at a program level, programs need to provide some fairly logical things: timely assessment and disposition for their patients, the budget, the space, and the nursing care for their patients, and they need to have some sort of a plan to manage patients in their queue. I think at a higher level, at the system level, we have to understand who is responsible to provide the services and where are we going to look for the answers. So what steps do we take? First, I think we need to clarify who's in the zone. You need to take note of your waiting room. What are your plans to manage your queue? And I think that if it's not clear what the expectations are, if people don't know what their job description is, they're not likely to perform to where they need to. So I think, again, if we have no destination, if we have no objective, no plan, any road will do. I think we need to establish an accountability framework. We need to track performance, as Les suggested. And I think that an accountability framework is the first essential step in developing a sustainable system. And I'm going to stop there.
That's great, Grant. Thank you very much. So what I'd like to do now is open it back up to the 3 speakers, panelists, to see if they have any further thoughts they'd like to share. And Mary, I guess we'll start with you. If you'd like to comment on what you've heard, if you have any further thoughts you want to share.
Just very complimentary presentation, so I was really pleased to see how they dovetailed. And I kept thinking as Grant was speaking to the specifics of who's in your waiting room, how do I get the system going, and what's my role in keeping that moving, married with what we all know happens really on the ground, that the most passionate, driven person to clear that waiting room in a systematic way gets frustrated because they're working with managers, administrators, whoever, that don't have the ability to quickly bring the resources to bear. They're working with physician staff who don't have the time in their schedule to think about how to redesign, much less may be resistant or may not, but even if they're very desirous to make these changes, don't necessarily have the time. And it really dovetails nicely back to what Les was saying in terms of how do we incent that accountability, and the work that the Health Service Purchasing Organization is really, in my estimation and in my experience that we've had in Vancouver Coastal, has really helped to focus all of us on those changes, outcomes that would make a difference, to support the frontline staff, the physicians in the emergency or throughout the hospital and the system to be able to make the changes necessary. I guess it's been a great way of focusing us all on the same thing as opposed to letting the somewhat chaos go on. I mean, there's many areas in the system which, I think of in my own job that, boy, I'd really like to make some traction there, and how do I start that out? And I guess that's what the accountability framework that Les spoke to with NBC does. It helps set those priorities. You may not agree they're the right priorities, but they're certainly important priorities, and it focuses all on those things, which really goes back to, what Les started with, well, why don't these companies have this problem? Why don't they talk about accountability, Holiday Inn or whatever? Well, because they're businesses, and they fight every day just to continue to keep their customers and to keep their costs balanced with their revenues. we don't have that driver, and many would say that healthcare can't and shouldn't be a business. Fair enough, but we need something to drive us towards the right work. So that's my takeaway from what I've seen.
Thank you, Mary. Les, did you want to add to or contribute to others?
Yeah, actually, well, Mary said most of what I had in mind. I also think it's interesting how three different speakers will, we have different points of view on this, and yet we're looking at the same thing. And so we're looking at it from three different directions, but it is the same thing we're looking at. In fact, there is a lot of commonality between the views, and big overlap. When Grant was speaking, and he was talking about the neurosurgeon and his mother, and the neurosurgeon not being there when something went wrong, I was thinking, well, it's sort of like the plumber saying, I'm sorry, but I'm disconnecting my phone after I finish the job, and you can't get me, so you have to find some other plumber to look after the mess that I made. And of course, the other plumber always ends up being the emergency department, as Grant says. So I'm there with him on that particular thing. However, in the end, it's not just the emergency departments. It's any different place that ends up being the wrong place for the patient, because we have no way to force the accountability. We have no consequences to that neurosurgeon. There is that neurosurgeon may not even know or ever find out that actually something went wrong there, or if he does find out, he doesn't find out that he didn't do something he should have done. He's never forced to really fix that for the next patient. The next patient could end up in the same place. There are no consequences for continuing doing things the way we are. And until there are consequences built up, there is someone who says, no, we don't want things to go in that direction. We're going to create a consequence for that you will not like. And as Mary says, in the world of other industries in the marketplace that Starbucks operates in, and everybody else like that operates in, there is a consequence for it screwing up. The consequence is people stop coming there, and they're going to go to somewhere else. Competition actually does do a lot of these things, and they can't afford those complications. They can't afford to have those consequences happen to them, and they know that. But in our system, we can afford to do anything we want. We can afford to keep going and nothing happens. So that's the part we're going to have to change, and we have a long way to go. Thanks very much.
Great. Thank you, Les. Grant, any other thoughts?
I just had a thought when Mary was describing disruptive change, which I think is necessary. I think we need fundamental change. It is very difficult. My hope is that if we actually clarified what we expect of people, then there might be less need to impose change or prescribe change. That's very difficult, because I think if people understand the expectations, they can actually be incredibly innovative, if they have to be innovative. Another comment, she mentioned that medicine's not a business. Unfortunately, I think medicine actually has to be a business. There's an old saying, no money, no mission. And if we're not managing the money, we're going to fail as a system. So I think as much as people don't like to see medicine as a business or healthcare as a business, it has to be a business. I liked Les's plumber analogy, and it sounded like he's in agreement that healthcare is not like plumbers, because in healthcare we have no expectations, we have no contract with the providers. He also brought up the concept of the value that's provided, and I think one of the things in healthcare that we do is we assume that whatever we do when we go to work has value, because if it didn't have value, we wouldn't do it. But the reality is a lot of the stuff, and as Mary said, 20 to 40% of the resources in the system really add no value. And so I think we do need a better understanding of what components of what we're doing actually add value and improve a patient's outcome. And I guess I had one question for Les, which was related to the statement you have to attach money. So what I'm wondering if you meant, Les, is if the patient was accountable from a money perspective, so if they were accountable for a part of the immediate cost of their care, are you suggesting that instead of saying I have a headache, I want a CT scan, would they say, do I really need that CT scan because I'm actually going to have to pay for part of it? So on the patient accountability side, is that what you're referring to? And on the provider side, are you suggesting that we need to take kind of the old DRG approach where a case is allotted a certain amount of money, and if you waste resources investigating the case, you just get less money for yourself or your program? Is that the kind of concept you were talking about?
Yeah, well, I'm not talking about the former because, first of all, it would work well if patients understood what they needed, and they don't, of course. And all we're doing is asking them to make choices that they're basically blindfolded. And also, you'd have to, in order to make those costs for the patient meaningful, they'd have to be high enough that politically it's not going to happen. And so that's not a way I see forward. The DRG method is the way I see forward. Now, we call it DRG. We're doing something similar in BC, as you know. We don't call them DRGs. I think we have actually a better system in BC than the DRGs, but I don't want to get into the detail there. The point is that the health professionals should know what's really needed, but values have to be assigned basically from the point of view of outcomes and from the patient's point of view. In other words, patients don't care how they get to being healthy, but they know when they are and they know when they're satisfied. So in some way, government should be acting on their behalf. In other words, acting as their broker. And the money has to give a message. It's not about the amount of money. We're not trying to pay people to put them in their pocket and make huge surpluses or profits. That's not the point. The point is the transference of money contains information in any marketplace. The fact that you're not getting money when and your business is not making money is giving you a message. And if you fail to pay attention to that message, then you're not going to stay in business too long. It's the messaging that's important with the transfer of money, and that can be reproduced in a market-like system that still isn't really a true market. And that's what we're trying to do here in BC.
Last, Julian, could you what is a DRG? Just for clarification, I don't know.
It's a diagnostic. It's a diagnostic-related group, which were created initially in the United States. Basically, it meant that it's a group of diagnoses that they want to treat as one. So appendicitis would be an example. An appendicitis case, it's a case, and they assign $1 cost and $1 values for it. So if you've got a case of appendicitis coming in, then it's worth, whatever, $3,000 or whatever. And then they fix the dollars to that DRG. The problem with DRGs is that they have proliferated out there to millions of different kinds. And some patients don't fall neatly into one DRG; they fall between DRGs. So then you have to create more DRGs to fill in those things. So it's become a bit of a monster on its own account, which is why we didn't go down that road in BC. But nevertheless, we do attach money to situations, common situations. And we do have a measure of complexity that goes along, which is what DRGs were designed to do.
Great, thank you. I just wanted to ask you three. This is the discussion you've had, and the thoughts you bring forward are excellent. How, in your experience and your perspective, how well aware is the system? And when I say system, I'm talking from the government to the front line and perhaps even to patient level. Is this accountability, is there awareness of accountability? And is there an acceptance or an agreement that there needs to be accountability? And do you get a sense of how far along that road we are? Are we just at the early stages and there's a lot more work to be done in that area, or is there a fairly good recognition that this does need to happen? And actually, I'll start with you, Mary, just to see if you wanted to jump in first.
Okay. I think for the most part there is accountability at the frontline staff level and the physician, et cetera. I think where it falls apart is that we don't have a system that allows people to be accountable. The system is not structured in a way that it's realistic for them to be able to do anything much more than what they're doing. So whether it's wait for a neurological visit for a year. I mean, that's not really the neurologist's fault. That's a system issue in that there either aren't enough neurologists, or we haven't triaged his wait list properly, or, whatever. There's certainly some joint accountability, but, we just don't have a system that makes it easy to do the right thing. And that's, I guess, what I spoke about. And I think there's quite a cost, not only financially to that, but also personally to healthcare providers who, to a point, work very, very hard to do the right thing and be held accountable to providing excellent patient care. But it's just not realistic that they can, do this 24/7, which is what it would require if even that would be sufficient to provide appropriate care. We need a better framework. Some of the ideas that Les is promoting are very much a part of a better framework, and there's a whole lot more beyond that as well, I think.
Great, thanks. Les, what do you think about the penetrance that this accountability framework has reached?
Well, I'd love to think that it's a huge issue for the public. Unfortunately, I think the reality is that people are looking, am I getting what I want? They're all looking in their own little things and saying, I want to feel safe that when I get good care, and as long as I feel safe. And then usually that kind of sense is based on false information, based on what they read in the media. They're easily frightened by things in the media, and they lurch from one topic to another. So I'd love to think the public is there. I don't see it. I think some governments are there, but I think that the governments have, larger issues. One is getting elected or staying elected, and the other is managing their budgets. And then this kind of thing in healthcare accountability comes down to a level of detail that people like Mary are, experts at managing, and governments are not. They don't know the detail. All they know is it's costing money. And so they have to trust people like Mary, people like Grant and I and others, many of whom are in the audience, and I suspect, to manage this in a proper way. And we never really get the chance to sit down together and work this out in a way that is for the common good. So I'd like to be more optimistic, but I don't see it yet.
Fair enough. No, that's fair. That's honest. I think there's a long way to go to align all the different layers to the healthcare system. Grant, your comments on that?
Just a real quick comment. I mean, I think people's sense of accountability varies hugely between the coalface and the Minister of Health's office, and I think people have very different senses of accountability. And I guess in general, you asked, if there's accountability at these levels, and I would say, if we think of accountability as a collective accountability to figure out how to deliver care to all the patients that need it, I would say no. There's no sense of that. And I think at least when you get to the level of physicians and nurses and providers, that we are looking at the one. We are not looking at the many.
Yep, that's a good point. I'd just like to. There's a question from the audience. It's from Erdem. And the question is, private organizations are accountable to their shareholders and their customers. The shareholder and the customer is the same for the healthcare. How can we make healthcare accountable to the elusive citizen, that is the customer, in brackets? Would this make a difference in the sustainability of healthcare system?
Interesting question, Erdem. I think I'd have to disagree that. I think the healthcare system is accountable also to the shareholders and the customers both in the same sense, because we're accountable to the government who funds us on the dollar side, and we're accountable to the patients we serve both. So in a way, it parallels the private organizations who are also responsible in two directions. Starbucks is responsible to serve me and make me happy, so I come back. But at the same time, they're responsible to their board or to their CEO or whatever to not run a deficit and use up money. So all of those things run both directions, and the trick is to align. So if you look at Starbucks, they stay in business. In other words, both the shareholders, both the board and the customers are happy when the detail is right, the pricing is right, the product is good, you have the right people in the right place to make sure that things don't go bad, or if they do go bad, they get fixed. And so that's the art of managing the detail. And in healthcare, it's the same thing here. We have, people like Mary to make sure the hospitals run the way they should, and they run cost effectively. So we manage our shareholders, which is the government, and also our customers or clients, who are the patients. So it's a trick of getting those two things aligned. And I think the example, it fits for both private and public.
Thank you. Mary or Grant?
I guess I have a quick answer. How can we be accountable to the citizen? I think we need to eliminate that 20 to 40% of waste, and I think we need to look at how we're distributing our resources. How are we managing our supply-demand problems?
Yeah. Well, I think it's the public needs to hold us accountable, and that's a long debate as to why the public's not holding us accountable, why they don't see a burning platform, why they're allowing governments to talk but not take action, because it's difficult to take political action, and so they don't do that. So that goes back to the underlying premise of why Jeffrey Simpson wrote that book, Chronic Condition, in terms of trying to get this debate before it's too late. That's a huge question. Why aren't people any more concerned than what they are and demanding action?
Good. Maybe one take home today is everybody picks up that book. Not that we're promoting Jeffrey Simpson, but if it needs to get out there, we should promote that as well. And where would you say the priorities are from our perspective in the front line or other levels would be in terms of helping move this forward? How can we? This discussion has been fantastic, but the challenge is it's not reaching everybody that needs to know about it, and even if people are aware of it, it may not be in their best interest to change. What do you think our next steps are? And certainly the work that you're doing, Les, with the performance payments, it's certainly a big step forward. But do you have any other thoughts about further to what you've already put forward?
Well, we have a long way to go. You can't make these changes overnight, or at least you could, but it would be hugely disruptive, and there would be a lot of casualties. So we're trying to do it slowly in BC and make incremental changes so that we're heading in the right direction. But getting to where we need to go is going to be a multi-year process, and I guess we need a bit of patience there. If we want to do it in a way that's not disruptive, it's going to take a while, and we have to hope that the people in governments don't change so fast that they lose sight of where we're going or where we started off doing, and that they stay supportive, and also that the public perceives the improvements on their side enough so that they have faith in the system, and increasingly that's our job to make sure we sell it, I guess.
Excellent. Thank you very much, Mary, Les, and Grant. I just got a message here saying that they have the same issues in New South Wales, Australia. So interesting how we've got the audiences that widely spread. So again, thank you very much. I'm cognizant of the time, and we're going to be cut off at 1 o'clock our time. So I hope that people have had an opportunity to think about this, and the session is being recorded. It will be put up on the Evidence to Excellence website in a couple of weeks, and it's www.evidence2excellence.ca. Please think of coming to the WeDoc conference, April 26th, 27th, and look forward to further webinars coming your way from E2E and WeDoc. And again, thank you, Mary Ackenhusen, Les Vertesi, and Grant Innes for taking the time and to sharing your expertise and thoughts on this issue.
Thanks, Julian.
Thanks, everybody. Bye.
Take care, everybody.
Bye-bye.